Grace and peace, everyone. Grace and peace to those who are on Zoom. Someone say grace and peace. Grace and peace to those who are on YouTube, Facebook. Somebody say grace and peace. Let me welcome everyone to our community and teaching series, a special edition on personal and public health. And what an exciting session we have planned. Indeed, this is our third session, and it happens to be our last with Dr. Michael Forbes. But let me be among the first to say it has been well worth it. What a powerful series of teaching from a powerful educator, doctor, leader. We have been all bettered by his expertise and his instruction. As I begin to frame, and before we pass things over to Dr. Forbes, allow me to simply say this, that we're living in a time in which it's important for us to rethink, reimagine, and repackage how we think about the faith. What I mean by that is what's important as we think about the faith is that we think how people need to apply what's in the scriptures. This is in large part what we're attempting to do through this special series. A part of the series is first and foremost to think about how we can take the principles of our faith, our biblically based principles, and apply them in real life scenarios in order to improve our personal health, in order to improve public health outcomes. In a real sense, it's our belief that Christians and people of faith have a role in being good stewards over what God has entrusted, that is our bodies. But also, we have a role in doing our part in making sure that the people around us and the world around us is in the best health possible. With that in mind, it is my pleasure to once again introduce our facilitator, our teacher. He is none other than Dr. Michael Forbes. He is a pediatric and adolescent intensivist, researcher, and physician executive at the Akron Children's Hospital in Akron, Ohio. Right now, Dr. Forbes focuses on unraveling the complexities of health services delivery for critically ill infants, children, and young adults. He's also the interim Noah Miller Chair of Pediatric Medicine at Akron Children's Hospital, as well as a professor and chair of the Department of Pediatrics at the Northeast Ohio Medical University. His recent efforts have focused on the integration of the myriad of clinical and administrative data sets to gain additional insights into systems of care across the entire continuum from primary care to recovery after hospitalization, as well as the impact of pediatric critical illness on families and communities. He received his bachelor's degree in chemistry from the University of Pittsburgh, then his doctorate from the University of Pittsburgh School of Medicine. Thereafter, he went on to complete his residency and was appointed chief resident at the Pittsburgh Children's Hospital of UPMC. He was awarded a fellowship in critical care medicine at the Pittsburgh Children's Hospital of Pittsburgh, followed by acceptance into the mid-career investigator program with the National Institutes of Health, Pediatric Critical Care and Trauma Scientist Development Program. In 2013, he completed the training at Woods Hole in Massachusetts. As well, he is married to Dr. Yolanda Moore Forbes since 1986. They were married in the Hill District of Pittsburgh, and they are the proud parents of 2 adult children. So as he comes once again to bless us in his own way, I want you all, whether on Zoom or Facebook, YouTube, Twitter, or you're calling in, I want you to do your best to welcome once again Dr. Michael Forbes as he leads us in this 3rd session on personal and public health. Let's hear it for him. Let's give it up for him.
Unmute Dr. Forbes.
Terrific. Can you hear me? All right. Pastor Lyde, thank you. Executive Pastor Walker, thank you. Everyone online, thank you. It's a real honor to be with you again and to talk about a subject that's near and dear to my heart, which is behavioral health. You may say, well, you know, what does an ICU doctor have to do with behavioral health? So I'll share that when I went into critical care, one of the things that interested me in critical care is that unlike adult critical care, where there was a myth, frankly, that the things that land adults in an ICU are largely self-caused, lifestyle-related, etc. Whereas the things that result in critical illness in infants, children, and young adults are kind of not their fault. It turns out that we're smarter than that today, and there's a lot of preventable critical illness in infants, children, and young adults. We see children who are abused, children who drown. So, you know, we who take care of critically ill and injured children know that every drowning is pretty much 100% preventable. And so being able to unravel and understand the process that leads to a preventable injury is really what so much of public health is all about. Our current pandemic, which was the source of the content of our first get together, is another terrific example of how even when we have known preventative measures, we make personal private choices that impact public health. And I think it's safe to say that when it comes to public health, you can make private choices, and I think all of us really believe and support the idea of personal human rights and personal choices. I would submit to you that you'd reconsider your personal rights when it comes to communicable disease. Because when it comes to communicable disease, you have to keep it to yourself. And there are ways to keep it to yourself. And if you make a personal choice that contributes to spread, that's really not a personal choice anymore. That's a personal choice that can harm others, continue a pandemic, and in fact, your personal choice has a butterfly effect. It can kill someone who you don't even know. So when it comes to communicable disease, I think it's the perfect example, the perfect use case to think about personal choices and its impact on public health. And so let's talk about behavioral health. I'm going to go ahead and share my screen, and I'll give you kind of a warning in a way that what you're about to see, is a bit of a flyover, I guess is a good way to think about it. My disclaimer is I am, excuse me, I am not a psychiatrist. my research when I was a fellow at Pittsburgh Children's focused not on behavioral health, but on the brain and on how the brain adapts and responds to trauma, physical trauma. And so I was very interested, and I'm still interested in traumatic brain injury, abusive head trauma in children, and how to take care of those children in the immediate first 24 to 48 hours after that type of injury. That's my extent of knowledge about the brain in detail as far as scholarship. As a physician, however, it's clear to me that unless we get our arms and minds and hearts around behavioral health and healthcare, it continues to be what I refer to as the hole in the boat. We can get, we think, everything right, but if we don't address behavioral health and the impact of the cares of this life on our choices, the impact of generational and intergenerational trauma on the choices that we make, all of our efforts will be diluted in their impact unless we are very serious and understand how to deal with behavioral health. Let's see. So who am I? This is just, I probably should have used this slide from the very beginning in sharing with you guys. And what you're seeing here is kind of my own background. This is my beautiful wife, Yolanda. I'm a really lucky guy to be married to a really, really smart, beautiful lady who loves the Lord with all her heart. And is an incredible Proverbs 31 kind of woman. So I married up. I know it. I'm proud about it. And life is really good. The two of us have been blessed with these two beautiful children who are now adults. This is our son, Michael, who's a few years older than our daughter, Nia. This is our dog, Hallie, who is not a guard dog, who just likes to eat a lot. You can't make this out, but this is Batman looking up into the sky because I'm a comic book collector as well. As you know, I did a lot of my training at Pittsburgh Children's of UPMC. I also was at West Penn for about 9 years in the West Penn Allegheny Health System. I was actually at West Penn and at Allegheny, and today I'm here at Akron Children's, really loving life. So lots of titles, lots of roles. I was ordained for the ministry. 1986 was an incredible year for me. And this is really by way of sharing my testimony. As I begin to talk about behavioral health, I'll share with you in a few moments how this all ties together. So Yolanda and I were married in June of 1986, but that's also the year I graduated from med school. One of the most incredible years, probably the most incredible year in my life. I graduated from med school in April, in April, was ordained in May, got married in June, started med school in August, and the rest is history. So we've been kind of running for quite a while. And this love affair is over 35 years old, so I'm really grateful. Became a dad twice again, praise God for that. Really got involved in public health, finished my critical care fellowship, and as Pastor Lai talked about, really great experiences and fortunate enough to be trained by some of the best educators and mentors on the planet. Really grateful and blessed for the life that God has given me. I'm going to talk about 3 different types of behavioral health diagnoses. And the purpose of this is not so that at the end of this, you can go diagnose your friend or your mother or your husband or your father. It's so that you can have a introductory vocabulary when it comes to how we in healthcare in general, again, not a psychiatrist, how we think about, certainly how I think about behavioral health and behavioral health conditions. Now, notice I'm not talking about mental health, because at the end of the day, we care about how you think, but we really care about what you do, right? When I was a fellow, one of my fellows, who will remain unnamed, in a moment of frustration because things weren't going the right way, he said to me, you know, Mike, we should be allowed to kill 5 people over the course of our lives with no consequences. And I called him by name and I said, wow. I said, you were really outraged. He said, yeah. He said, I wish there was a way we could do it and have nothing bad happen to us. And I said, well, I'm kind of grateful that we can't. But I know how you feel and I understand how you're thinking, right? But what we really want to be able to do is think what we want, right? But you want to make sure that your behavior is healthy, right? And your thought life drives your actions. And as we like to say, and again, in healthcare, if you don't let people talk it out, then they act it out. And so the key there is you need to have somebody to talk to. You need to have someone who you can talk to who is your secret keeper. All of us need a secret keeper. Some of us need more than one. And I will say, as a man, and we'll get into this in a few moments, men are different than women in a lot of ways. The male role and the female role in this culture is very different and sets us up for behavioral health diagnoses differently. So we'll talk about depression, where blue is more than a color. We'll talk about thought disorders, where it may in fact be just your imagination, but you can't tell. And then we'll end with anxiety disorders. And again, there's a whole library of behavioral health diagnoses. You may all be familiar with the Diagnostic and Statistical Manual. I think we're at version 6 right now, or 5. Again, I'm not a psychiatrist, but this is a dictionary, if you may, reference guide that is evidence-based, that really every few years, the experts around the world come together and say, is major depression what we called it in the last version? Because there is research going on every day, all the time, to get more clarity when it comes to diagnosis, management, early recognition, prevention. So there's lots of work going on around behavioral health, and the pandemic has frankly made things a whole lot harder. The burden of the pandemic on people emotionally, physically, spiritually, really, I don't think we really have a grasp yet, but it's huge. We are seeing record numbers of these behavioral health diagnoses and the negative impact of social isolation and being disconnected and misconnected from others, anxiety in parents being transmitted, frankly, to their children, and really exposing, I'm going to make my own observation here, it's not evidence-based, but what I've learned in this pandemic is a lot of people don't have people. A lot of people do not have people. They're all alone, and it shows. So there are 3 major mood disorders. And when we think about behavioral health diagnoses, there are mood disorders, there are thought disorders, and there are certainly other types of disorders as well. But the 3 major mood disorders that we'll kind of touch on, again, just to get you familiar with the vocabulary, are major depression, dysthymia, that you may or may not have ever heard of. No one inserts dysthymia into a movie script, but you can watch TV or go to a movie and you'll hear about depression, you'll hear about bipolar disorder. No one really talks about dysthymia. So depression is much more common than any of us think. 1 out of every 10 Americans are diagnosed with depression. And you may look at that and say, well, 19 million is not 1 out of 10. There's 330 million Americans. And so this includes adults who can be diagnosed. And we'll get into whether or not children can be depressed in a moment, but just know that it is extremely common, right? So how many people are on this Zoom? The last I checked, there was like 17. There's probably about 20 now, let's say. And so it's safe to say that a couple of us on this call, either now or later, will suffer from some form of depression. And in fact, the lifetime risk is about 4 to 5% over the course of a complete lifetime. That is to say, about 4 to 5%, almost 1 in 20 of us, will be diagnosed with major depression at some time. Depression results in a lot of unnecessary suffering. It can interfere with normal functioning. It can absolutely destroy family life. It can lead to medical illnesses as people self-medicate to deal with their blueness. And of course, there are real financial consequences of major depression. If you are diagnosed with major depression, or if you're suffering and you're not diagnosed, which means you're untreated, it's much more difficult to keep a job, maintain relationships, etc., because you're doing the best you can, but you have no idea that you have this pretty substantial monkey on your back. Most depressed people are actually unaware of their illness. When I was a fellow, I look back now, again, this is in the late 90s, there was a period that was around the holidays where the best way I could describe what I was dealing with, and I only appreciated this years later when I was looking back, where the world turned into shades of gray. There was no color. And I will tell you, even the people who knew me well had no idea what I was dealing with. I was going through the motions. I showed up for work on time. I did a good job. I got raises. I was doing everything I was supposed to do. But boy, the world was not right. Okay. And I look back now and I realize that I probably met criteria for a bout of major depression. And my point in saying that is to also point out that even among psychiatrists, there have been retrospective studies that have, and they're limited by study design, recall bias, and so on. But even among psychiatrists who do this work every day, they can recall multiple episodes of depression that were never diagnosed clinically. And so among lay people, I'm pretty sure that many of you on this call may have had episodes of actual major depression that weren't called that. And so I think it's really important to just be aware of how subtle and how insidious it can be. Pardon me. It's okay. Can you hear me? Thanks. There's my dog. So most people who are depressed would rather call it something else. But if you love someone who is battling major depression, you know that it can ruin their lives. And in fact, it can be generational. And it can ruin their lives in the prior generation and then currently in this generation as well. The good news, and we'll get to it in a moment, is that whole person therapy matters. And by that, I mean, while there may be a biochemical reason for it, a home of origin issue for it, medications and therapy, counseling have been proven to be very, very effective in folks who are properly diagnosed. And so I think it's safe to say there is hope. For those of you who are on the line who wonder about the neurobiology of how you think and how you feel, you either don't understand it or you frankly may not even believe it's real. The biochemistry and the neurobiology of how you think and how we feel is incompletely understood. However, it is absolutely undeniable. A good example I like to use when I have this discussion is, I remember one day when Yolanda was expecting either Michael or Nia, I can't remember, but I came home and I walked into the bedroom and she was sitting on the bed and she was crying. And I said, "What's wrong?" Right? Trying to help and support her. And her answer to me, I'll never forget it. She said, "I have no idea. I have no idea." And that's because the hormones associated with gestation and pregnancy can in fact make you much more emotionally susceptible, much more labile. You experience things that you don't want to experience. You think things that you'd rather not experience. You may have more prone to be blue, more prone to be anxious. And these are just a few, frankly, of the hormones and what we call neurotransmitters that are responsible for how we think and how we feel. So dopamine is in the news a lot because of the addiction, opiate epidemic, the cocaine epidemic that's been going on for obviously many years. Those chemicals stimulate the dopamine system and give you a sense of pleasure and reward, elation, keep you up, may increase your attention to some degree, but you crash because it's not normal. And so you end up needing more stimulation for your dopamine receptors. Serotonin is another neurotransmitter, norepinephrine, epinephrine. We've learned in the past 5 to 10 years about the cannabinoid system and the role of THC, which is the active ingredient in marijuana, how that affects your mood and anxiety and how you think and how you feel. And so there is clearly a biochemistry here to all of the behavioral health diagnoses. And again, incompletely understood, 100% undeniable. And so if you struggle with this, specifically if you're a person of faith, if you're a Christian, and maybe your Christian tradition says, if you're depressed, you're not trusting God. If you are sad, it's because you lack faith. You need the faith of a grain of a mustard seed and trust God. And if you believe God, then you wouldn't be sad. I would challenge that, right? Because our example certainly can be Paul or Peter or John, any of the apostles, but our best example is Christ. And when Christ was facing the cross, he went into the Garden of Gethsemane, right? And he was in prayer to the Father, praying that he didn't have to go through with this. And the Bible says that his tears became like drops of blood. And so if the Son of God, in the perfect will of God, doing everything that he is supposed to do, is dealing with the cares of this life with such sorrow, I frankly think I have license to do that too, and so do you. So I don't believe that Christ in the Garden of Gethsemane was in sin. I do not believe that in the Garden of Gethsemane he lacked faith, forgot who he was. It was in his humanity. And this life is not fair. This life is really tilted, and bad things happen to bad people and good people. The sun shines on the rain. God brings rain on the just and the unjust, right? And so we have to be careful as people of faith, and as Christians in particular, that we not allow cultural teachings to rob us of the richness and revelations of God. And if you remember in the Gospels, what Jesus did with the Pharisees and the Sadducees is he was constantly correcting them about what they taught as tradition and culture as facts. He said, you teach the traditions of men as the oracles of God. And I would challenge you if you are a Christian to make sure that your beliefs and how you think about things is biblical, and that you can respect what's cultural and you can respect what is tradition in your family or in your church. But at the end of the day, it is the glory of God to hide a thing in Proverbs 25, and it's the glory of kings. In our day and age, I believe that's our scientists to find it out. And so when God is given revelation, I would encourage you to not allow culture and tradition to blind you to the benefits of contemporary medicine and how we understand how we think and feel. Again, the neurobiology of how we think and feel is incompletely understood, but it is absolutely undeniable. Depression is not being blue. Everybody feels blue every once in a while. Depression is not a sin necessarily, though it may be rooted in sin or poorly developed love relationship with God. It is not a weakness, nor is it an excuse to sin, right? The devil made me do it. Well, that's not going to fly, right? Nor is it something that can be wished away. And if I had a nickel, better yet, I want more money. If I had $1 for every time one believer said to another believer, trust God, you won't be depressed. If you believe God better, you wouldn't be so sad. I'd be so wealthy. Okay. And again, that's when tradition and culture are being taught as the oracles of God, and it has hurt a great many people. Like many illnesses, depression has many forms. These are some of the symptoms, no surprise. Sadness, anxiety, just feeling empty. Like I said earlier, life loses color. It's like it's totally washed out. Food doesn't taste right. Sleep is evasive, or you sleep in a whole lot. It goes both ways. Feelings of hopelessness, feelings of pessimism, guilt, worthlessness, helplessness, not having enough energy. These are all symptoms of major depression. So symptoms can affect how you work, how you learn, your relationships, how you sleep. And be careful here. People who are depressed can have insomnia, and people who are depressed can sleep and not feel like waking up. Strangely enough, it goes both ways, which is why you need a psychologist or a psychiatrist, someone who does this for a living, to make the diagnosis of any of these behavioral health diagnoses. Eating, again, it goes both ways, sleeping and eating. You can eat nonstop because you're depressed, and you can starve yourself almost to death because you're depressed. So it really goes both ways. Everybody's different. But the other thing that you also have is that you stop enjoying things that used to give you pleasure. Okay. It could be a single episode, and some people do get away with just one, and other people have multiple episodes over the course of their lives. So be aware. What about dysthymia? Dysthymia, again, is not talked about a lot, but it may in fact be a little more common than major depression. Again, major depression is those symptoms that I just talked about, usually for at least 2 weeks, if not longer. Dysthymia is a little bit different. Dysthymia is, you can imagine that person who never gets too high emotionally and never gets too low emotionally, but they don't really enjoy like most people would enjoy these things. So it tends to be less severe. The symptoms tend to be long-term. And the tricky part here is that it doesn't typically disable the people who are struggling with it. But it does prevent a thoroughly fulfilled life. There may be anxiety in there, an unwillingness to try new things because, things that you already know give you less anxiety. And it's, I describe it here as living in black and white, not in color. And they often experience true depressive episodes from time to time. So again, dysthymia may be way more common than major depression actually is, and it's even more difficult to pick up on. So again, major depression, dysthymia, and now let's talk about bipolar disorder. I think the one thing I want you to come away with at the end of this discussion is bipolar disorder is not a joke. One of my psychiatry colleagues referred to bipolar disorder as the spinal cord injury for the psychiatrist. And talking to me as an intensivist, when I have a 17-year-old who breaks their neck, who can't move their arms and legs, that is an incredibly devastating injury. But the diagnosis of bipolar disorder for many psychiatrists is that level of angst. The impact is that level. So it is not a joke. We don't tease and say, oh, you're bipolar, although you can hear people say that. And again, it's people who don't actually understand what bipolar disorder actually is. It is a profoundly disabling behavioral health diagnosis. The World Health Organization recognizes it as one of the top 3 reasons all-cause hospitalizations in people 15 to 44 years old. 5%, that's 1 in 20, are affected. 1 to 2% are actually diagnosed. So about 3 to 4% of us may have bipolar disorder and are not diagnosed. About 4.4% of all Americans are diagnosed over the course of their lifetime with bipolar disorder. That's data from the National Institutes of Mental Health. This graph really gives you kind of a schematic, a model, a framework to think about these 3 conditions. So when you look at mood, at the very bottom here, depression is the lowest mood. Mania is the highest mood, lots of energy, lots of go, go, go. Hypomania is what it sounds like, not quite manic. And euthymia is where most of us, I think, want to be most of the time. As far as our mood and how we're feeling, you wake up in the morning, you're grateful for what you have, you count your blessings, you do your job, you take care of other people, you love people, you're loved by people. That's euthymia. And most of us, I think, really are trying to live in that space. But then there's bipolar. Bipolar 1 is associated with these high highs of mania and the low lows of depression, right? So who wants to live like that, right? Nobody wants that. This is really not how you want to live your life. And they do, of course, can be euthymic as well. Cyclothymia is, you're a little hypomanic, not quite depressed. You're never at the extreme, but you can also have this cyclothymia. And then there's bipolar 2. Where you tend to be hypomanic, not manic, but you certainly are a little more prone for depression. And so that's the mental model in psychiatry and psychology for how they think about the mood disorders. Many of bipolar is a recurring disorder, and again, it can be cyclic as well. And so when you hear people talk about this who are clinical, this is what they're talking about. The key here, I want you to come away with it is it is absolutely treatable. And so 25% of those treated will live with bipolar 1 for a long time. Some people are treated and they're off of medication and they're back to their life and they're euthymic most of the time. They may or may not remain in counseling, but understand that being treated with medication for bipolar disorder is not a lifetime for 3 out of 4 people who are treated. Okay, but I wanted to highlight some of the symptoms of bipolar disorder. And the first one here is this mania and deep depression for bipolar 1, as we just saw in the graphic. So grandiosity. So what's that? It's exactly what it sounds like. You know, it's King Nebuchadnezzar in Daniel chapter 4, right? Who reaches a point in his life where he stands on the roof and looks out over his kingdom and says, wow, look at me, look at what I have done, and proceeds to pronounce all of the things that he has done, which is just magnificent. But he learns later on that that's not the right approach. So an exaggerated belief of your own importance, sometimes reaching delusional proportions. Okay, and what's a delusion? A delusion is a false belief strongly held even after being confronted with contrary facts. Okay, so in science, in medicine, there are no alternative facts. There are scientifically proven things, and there are things that are being investigated by science. We have facts, we don't have alternative facts. It's either a fact or it's not a fact, right? And delusions are, again, strongly held beliefs despite evidence to the contrary. A diminished need for sleep if there's a mania. Excessive talking, pressured speech, what we describe sometimes as flight of ideas. You're going from one thing to the next, to the next, to the next. Clearly distractible, cannot focus, starting 30 different things at the same time, finishing none of them. An increased level of goal-focused activity. I'm going to clean my whole house and your house, right? So some of you may say, well, that doesn't sound too bad. It can be, right? Because they're going to crash, right? This is bipolar 1. They're going to go into that super deep depression that's going to take a lot to pull out of. So nobody really wants to clean 3 houses in their neighborhood and have everybody love them and then spend the next 5 days in bed crying, right? That's not life, right? We're looking for balance. Excessive pleasurable activities like spending more money than you have, multiple sexual partners. I mean, mania is exactly that. And again, 15% of those treated will live with bipolar 2. So again, 85% are treated, and it is not lifetime. So I think that really is the good news when it comes to bipolar. Again, I'm emphasizing the point here. This is not glamorous. This is not a joke. And I'm probably emphasizing because I hear people joking about being bipolar or saying someone else is bipolar. No, this is not that. Persistent depression symptoms can, again, affect you financially, relationally, personal health as you self-medicate. And again, we've talked about the examples of mania. Depression, and I loop this into the bipolar discussion because, of course, bipolar 1, you can be at both extremes with mania and very deep depression. Bipolar 2, you're not quite manic. There's hypomania, but there's depression. So depression is a part of both forms of bipolar disorder. And there is the genetic component of all of this. Yep, you can and will get it from your parents or your grandparents or your uncles or your aunts. So your family history when it comes to behavioral health diagnoses absolutely matters. And of course, culture, right? If you watch how people cope with stress, if you observe how your parents or your grandparents or your family in general is coping with disagreements and disappointments and the cares of this life, that's what you know. And so for some people, they need to be recoached. They need to unlearn some things. As one of the leaders in my men's Bible study likes to say, some of us need to be refathered. And I think there's a lot of truth to that. And so there is a nature part. Our genes are what they are, but there's a huge socialization, nurture component to it as well. Depression does run in families. Bipolar disorder runs in families. And again, I will say, I'm separating these to some degree, but I want you to appreciate that there is significant overlap. And there are some psychiatry and psychology frameworks that actually will take depression, bipolar disorder, schizophrenia, ADD, and create a giant overlapping Venn diagram. Because depending on your age, your gender, your race, your culture, your occupation, which psychiatrist or psychologist you see, you may in fact be diagnosed with any one of these at any time over the course of your life. And that's not to say that the clinicians that are doing behavioral health are kind of willy-nilly and random. The trick with behavioral health diagnoses is there's no throat culture for depression, right? So Pastor Lied, if you came to me and said, brother, I have a fever, my throat hurts, I can do a throat swab and say, yep, you've got strep throat. And what we call the diagnostic stability of that diagnosis is 100%. Okay. On the other hand, if you came to me at 17 with a symptom complex, you may be diagnosed with ADD. 10 years later, after living your life, you may go to a different person who'll say, it really sounds like you have bipolar disorder. My point is, life is quite complicated. And as the more evidence we get behind all of these diagnoses, and the better you have a relationship with your provider, your mental health, behavioral health provider, the more success you're going to have. And I say that to say, if you have gone to counseling and it hasn't helped you, it doesn't mean that counseling doesn't help you. It means you have to find another counselor. Your relationship with your psychiatrist, psychologist is a very important component as to whether or not you improve when it comes to behavioral health. And that's nuance, but a very important point in how we think about mental health and behavioral health, treatment and management. If you have a heart attack and you show up in the emergency department, you do not need a relationship with any of the caregivers in the emergency department to get better, right? In fact, some of you don't even want that. You just want to get better and get out of there. When it comes to behavioral health, that's not that. You have to have a healthy therapeutic relationship with your counselor in order to have the best outcome. So if it's not working, I would encourage you to discuss that with your therapist, your counselor, and find another one. And they may even be able to recommend you to somebody, but do not give up if you have this diagnosis and start treating yourself. That would be like having a heart attack and saying, I don't want to deal with the ER or the cardiologist. I'm going to wait and see if this goes away, right? It's a bad decision. So common genetic markers make the disease more likely. We have a whole panel of genes that are being identified that are behind bipolar disorder. Some people are heavily weighted genetically and they're very affected clinically. Some people not so. And there are some people who are very clinically affected and we can't find any genes associated with bipolar disorder. And the reason is the entire library of genes behind a given diagnosis is incomplete. But as time goes by, we're going to be clearer and clearer on which genes are responsible for some of these disorders. There are other illnesses that can trigger depressive episodes. You can become depressed after a stroke, after a heart attack. These are life-changing diagnoses, right? MS, chronic disabling diseases, diabetes, many chronic diseases after the diagnosis is made is associated with what may be called not major depression, but what's called an adjustment disorder with depressed mood. In other words, you've been diagnosed with cancer and that's going to punch everybody in the face, right? But if a month later, and it's not chemo related, right? Or it may be, you lose your appetite, you can't sleep, you start disconnecting from your friends and your family, you may in fact be dealing with depression. And it may be chemo related, but you better be under the care of a behavioral health specialist as well, because if you miss that, your outcome from your cancer is worse. And so it's really important if you have chronic disease that you have a therapist. And I am a huge fan of behavioral health therapy and counseling, particularly for Christians. In my church here in Akron, one of the courses that I had to take when I first came to Akron 15 years ago was a course in grief recovery. And one of the things I learned in grief recovery, this is an interesting course, but one of the first things they did is you have to leave your Bible at the door. And I thought it was kind of strange in a church offering a course on grief that it wouldn't be like biblical. Well, it was quite biblical. You just couldn't use your Bible as a crutch. You just couldn't use Christian cliches to deal with your grief, because that's not dealing with grief. And so the course really emphasized that you needed to call a spade a spade. And if you've had a stroke and you can't move your right side, it's okay to have faith in God that you'll get better and be depressed and be hopeful. Like all three of those can exist simultaneously. But if you're not given license to think like that, you're going to think that maybe it's because I don't have enough faith, or maybe God doesn't love me like he says he loves me. And you're going to need some counseling and some coaching to deal with the fact that you can't move your left side anymore. That's a big deal. And so chronic diseases are notorious for triggering not only adjustment disorder with depressed mood, but they can also trigger major depression. There is a gender difference when it comes to the diagnosis of depression. Now, I gave this presentation back in 2005 in Pittsburgh as a 6-week series at Bethany Baptist Church. And so you're getting like 6 weeks in 45 minutes to an hour. And so what I'll point out about this is that the way we make the diagnosis of depression, again, many behavioral health diagnoses depends on your counselor, where you are in your life, what story you tell them, okay? And so if you're really good at covering up your problems, you're not helping yourself, okay? And one of the things that's different about men and women in general is women are much more likely to cry if things aren't going well. Men are taught in our culture that if you cry, you're weak, right? So men learn how not to cry even though they're in pain. And so you've got to be really good to pay attention to the things that matter if you're going to diagnose depression in a man. So when you hear that depression is more common in women, again, that's World Health, that's NIM, National Institutes of Mental Health, all have this statistically proven. But I would submit that as time goes by and we get more evidence, I don't think there's a gender difference at all. I think it shows up differently in men versus women, just me. But again, the evidence says it's more common in women. So are there hormonal factors? Absolutely. Women who are pregnant will describe that emotional lability. Postpartum depression is not a lack of faith. That's a real thing. There's a lot of factors that play into that. Please don't deny the existence of that. People can be harmed by that, actually. Losing all of those hormones that have been flooding your brain for 9 months changes you. So that is a real thing. Miscarriage, I mean, losing a baby can obviously very devastating. Having a new baby can actually be, devastating. It can be a really overwhelming moment for a woman, for her family. And again, the cares of this life, right? Work, your family, the presence or absence of a spouse, your kids, adult dependents. There are lots of things that can trigger those of us who are at risk to become depressed. A quick word about PMS, or premenstrual syndrome. It is absolutely real. You may already believe that or know that, but what we've done in the past, this is 2 classic studies done, published through the National Institutes of Mental Health, where hormone blockers were given to women, which showed symptom relief. And then they gave them the hormones and the symptoms came back, right? In patients who don't have PMS, this sequence of events had no impact on them behaviorally. And so there are women who are biologically set up, predisposed to having premenstrual syndrome and symptoms that can range anywhere from being irritable and a little bit anxious to absolutely almost dead depressed. And so we have to be mindful and sensitive to that. And again, the biology of how we think and feel is incompletely understood, but 100% undeniable. So what about men, like real men, right? Do men get depressed? Absolutely. So the myth in our culture, and certainly in the Christian church, where there's been a fair amount of machismo over our history, right? Real men suck it up. Real men have real faith, real men trust God, and real men don't get depressed, except Jesus, right? So I think we just have to be real with ourselves that being depressed is a part of the human condition. It's not a sign of weak men. It's not a sign of soft women. It is a part of the human condition. Real men are less likely to suffer than women, but I will submit to you, you can see the numbers here, about 4 million men are in fact affected by depression. Real men actually will complete suicide 4 more times than women. Although women are more likely to attempt suicide, men are much more likely to use lethal means like hanging and guns. Furthermore, men after the age of 70 there's a spike shortly after the age of 70 in male suicides, particularly in white men, that peaks after the age of 85. Many have theorized that this spike after the age of 70 is related to the phenomenon of men who identify very strongly with their work. That includes people of faith, that includes people who are in ministry. Once you retire, you lose your purpose, is the theory. And because you're disconnected and you haven't maintained friendships, and again, a lot of people don't have people, you lose kind of your will to live, and you can become suicidal. So absolutely real. The other thing that plays into this is that many diseases show up around 60, 65, right? So in addition to not working anymore, you may be diagnosed with Parkinson's or cancer or whatever, right? So lots of things conspire to make it really tough on our elders. And so I just want to call that out, that it's a real thing. There's nothing protecting Black men. This is just that the data shows that it's particularly high among white men, but Black men are just as affected or likely to be affected. A depressed man is hard to find. Men don't admit it. Men don't suspect it either. You could be around your buddy and you will have no clue, right? Because men cover it up really well. But the question I like to ask men is, do you have a 2 o'clock friend? Not a 2 o'clock in the afternoon friend, a 2 o'clock in the morning friend. A brother you can pick up the phone and call him, not text him. A brother who you can pick up the phone and say, yo, I need you, right? Bro, I need to talk. Yeah, get out of bed, go downstairs. I need to talk. And if you don't have a 2 o'clock in the morning friend, I would submit to you, you are at risk, because life's tough. It's not fair. And you need people. And as I mentioned earlier, everybody needs a secret keeper or two, because life's like that. Doctors are also less likely to suspect it or look for it in men. And depressed men, frankly, do not look like depressed women. So what does a depressed man look like? Well, they mask their illness with drugs and alcohol. So you may say to yourself, Uncle Mike is an addict. Well, I would submit to you, maybe Uncle Mike is an addict, but maybe Uncle Mike is depressed, and he's been that way for a really long time. And so maybe it's time to step back and rethink how we think about addiction and drug and alcohol abuse in our culture, because many people are simply self-medicating. The other way that depressed men show their behavior is they don't cry in their beer, they work. They pick up overtime, they pick up extra shifts because that gives them purpose. It's a terrific distraction, but when they're not working, they can be intolerable or unavailable. They either sleep a lot when they're around their loved ones, or they don't engage, but when they're working, they are fully engaged. And so this is how, men, I'm calling you out. I'm trying to help somebody. So they also don't appear hopeless or helpless. As I said here, real men don't cry. But again, they're irritable. They're prone to rage. They're prone to be discouraged. They complain a lot, way more than you'd expect them to. And so they're battling, and they're battling right in front of you. And the way that they get settled is they work more. Or again, it happens in ministry as well. I really want to point out that, we think about like the corporate executive or somebody like that, but just because you're in ministry doesn't protect you from any of this. In fact, it may increase your risk, right? So you want to be careful as a believer that you don't get caught up in the play acting that is very common in Christianity and in many faiths, where you have to stand up straight and keep a smile on your face because it will set you up for incredible untreated depression. And they're also less likely and less willing to seek help. So can kids be depressed? Absolutely. And so what do you see? School avoidance, feeling misunderstood, complaining a lot. A part of me kind of tongue in cheek says they kind of act like men who are depressed. So they don't drink, and they don't cry necessarily, but this is what kids do. They feel misunderstood, they complain a lot, they isolate. And one of the things we do as pediatricians is we want to make sure, because a lot of physical diseases will make kids depressed. And if you just start them on antidepressants, you missed a boat, right? So are they hypothyroid? Do they have liver disease? Do they have kidney disease? Okay, all of those conditions can actually make kids depressed. They lose energy, they don't feel right, and you can see the depressive symptoms, but make sure, and again, a good pediatrician is going to make sure they rule out all of the common illnesses before they say, yep, this is a major depression. And of course, therapy decisions vary as a function of age. And a word or two about therapy and medications. Many people in the Christian community have zero interest in medications when it comes to, frankly, anything. Right? They believe in the body's ability to heal. They believe in the body's ability to do incredible things. And I would absolutely agree to a point. The fact is, we are fearfully and wonderfully made. And everybody does not need medication. We do have some meds that are listed on here. There are lots of options. This is hardly an exhaustive list. There is a long list of medications to treat depression and the associated symptoms. But for me, the question is, why medications? None of the medications to treat any behavioral health diagnoses are effective alone. Not a single one. Medication plus counseling, therapy, coaching really is the way that you deal with behavioral health. Okay. And again, you're not treating a pneumonia. You're treating how you think, how you feel, how you relate, how you think about pleasure, how you think about pain. Okay. And so this is not something you take a pill and your depression goes away. You need to be coached and counseled and receive therapy about how you think about things. But where medication can help when it comes to behavioral health is it can help you to clear the fog of the illness so you can benefit from counseling. That's how I think about it. For some people, they are so depressed, counseling does nothing. They have no energy. And for some people who are very depressed or anxious, the medication will activate them, allow them to engage, have that necessary conversation, and that becomes therapeutic. But if you're so depressed that you have what are called negative symptoms, you're disengaged, you're sleeping a lot, you don't have conversations, you stop talking, then you're not going to benefit much from counseling. But the medication can sometimes reverse those negative symptoms so that you can at least engage and work on your wellness. They can usually elevate your mood, often not permanent. There are some risks that are described here. A couple myths worth addressing. As I think about the medications that are used for major depression, certainly for bipolar disorder, none to my memory, and I reviewed a few of them, are not addicting. So you don't become addicted to your depression meds. The second thing that's really important is it is not permanent. I alluded earlier to bipolar disorder, where 3 out of 4 people are treated. They may remain in counseling for a while, but as far as medications, these aren't lifetime prescriptions for many, many, many people. Now, a word about St. John's wort or hypericum. It has been studied, and for mild to moderate depression, it does elevate your mood. It's cheap, it's over the counter. So it does work for really mild symptoms, and maybe for people who are dysthymic, it may in fact make a difference for them. So there is some evidence there that may work over the counter. So what else works? I think spiritual renewal works. And that may take many, many different forms. But again, the way you think about yourself, the way you think about God, all of that plays into how you perceive reality and how you're going to make yourself well, right? And as we say these days, live your best life. Psychotherapy definitely works. Medications, having realistic goals works. Breaking large tasks into smaller ones, having a good counselor, good therapist with a reasonable treatment plan, finding and making a confidant. Again, I can't say it enough. Everyone needs a secret keeper. And frankly, everyone should be a secret keeper to somebody. And exercise, any exercise. The body is amazing. Any exercise will absolutely transform your biology and make things better. So what's reality? The reality is people rarely snap out of a depression. Okay, so stop telling people that. The reality is they get better day by day. The other reality is garbage in, garbage out. So if you're struggling with depression or anxiety or any behavioral health diagnoses, you have to be careful about what you watch, what you eat, who you hang with, right? I mean, I have kind of a no drama policy in my relationships, and I have boundaries in my relationships. And I would submit to you that all my healthy relationships have boundaries. All my healthy relationships have boundaries. And think about the relationships where there's drama in your life. It's because the other person doesn't respect boundaries. And so you have to learn to establish boundaries and then let people help you. Schizophrenia, I'm gonna, again, I can forward this on to Pastor Lyde for distribution as we hit the 8 o'clock hour. 20 million people worldwide are affected by schizophrenia. It's from the Latin, it means fractured brain. The struggle for people who have schizophrenia is they tend to lose touch with reality. They need to be able to reality test and reality check. And if you have schizophrenia, it's really, really, really difficult to tell real from not real. Like bipolar disorder, there is considerable disability. Premature death is 2 to 3 times higher in patients with schizophrenia than not. A lot of the deaths are due to other diseases. They tend to smoke a lot because there's a huge anxiety component. So lung cancer, chronic obstructive lung disease is very common. Stroke, heart attack, very common cause of premature death in folks who have schizophrenia. Anxiety disorders, as I wrote here, when worry is easier than anything else. These are 4 of the common forms of anxiety. There's generalized, which is an interesting diagnosis. I've had friends who swore when they were first diagnosed with generalized anxiety disorder that they were having a heart attack. One person I remember was at work, and what they described is they had sudden chest pain. They were sweating. Their heart was pounding out of their chest. They were kind of overwhelmed. They started having pain in their chest that wouldn't go away. Went to the hospital, everyone thought they were having a heart attack, and it turns out it was a panic attack. And so panic attacks can come, and again, this is generalized. This isn't a phobia, right? This isn't a fear of dogs or cats or heights. This is you're sitting there minding your own business, and your body is likely responding to buried stress, buried stressors, and suddenly just flips the switch, and you are not in control of that. And so it's really important to handle your stress. We've heard about OCD, there are social phobias, and certainly post-traumatic stress disorder can look like ADD, can look like bipolar disorder, can look like major depression. PTSD is a really, really common, troubling diagnosis that can also be profoundly disabling. Common features of anxiety disorders are excessive fears about everyday circumstances, okay? Irrational dread, catastrophic thinking, perfectionism, right? It has to be just so. An inability to adjust and cope with changes in life. A tendency to sameness is another feature of anxiety disorders. You may watch the same movie over and over and over because frankly, you know the end and you're not going to be surprised. And so that's kind of one of the ways that it's manifested. Obsessions are thoughts, compulsions are actions. And so obsessive compulsive disorder are thoughts that invade your brain, coping strategies that you do that aren't healthy. You may say that's just the way I am, but OCD can be extremely disabling as well. These are 2 quotes from folks who've had panic attacks. And the top one I'll read, it says, "For me, a panic attack is almost a violent experience. I feel disconnected from reality. I feel like I'm losing control in a very extreme way. My heart pounds really hard. I feel like I can't get my breath, and there's an overwhelming feeling that things are crashing in on me." So imagine that. Imagine getting a panic attack, sitting there, minding your own business, doing absolutely nothing. And so this isn't getting anxious and worried and then ramping up. This is like a light switch for many people. And once it starts, it's pretty debilitating. So 2.4 million Americans, twice as many women as men, tends to show up in late adolescence. There's a strong family link about how you cope again. Not all panic attacks result in panic disorders. Lots of people have panic attacks who do not have panic disorder. And again, it can be quite disabling. Panic disorders do disable. And I want to point out that many people who have panic issues and anxiety issues tend to abuse alcohol, can be depressed. They tend to abuse, they can use drugs excessively. They tend to avoid normal everyday situations. And many, sadly, are housebound. They won't even go to the mailbox to mail a letter because of their anxiety disorder. So I wanted to give you an overview. This is a big flyover, but really wanted to kind of set the stage and answer any questions that you might have. And I want you to come away with this with a sense that culture is real, your home of origin is real, your upbringing is real, your biology is real. We are fearfully and wonderfully made. And what has gotten me through all of the things that I've gotten through, and I know for many of you it's the same, is what I believe is my only hope in this world and our only hope in this world. And that is the persistent, faithful love of God. No matter what is happening, we can depend on him to take care of us no matter what is happening in this world. So thank you. And again, take care of yourselves and those you love. Pastor Lyde.
Thank you so much, Dr. Forbes. Will everyone, whether on Zoom, YouTube, Facebook, Twitter, or call in, will you join me in thanking this powerful doctor,
Thank you,
this
sir.
powerful man of God, for just being so thorough in his instruction to us? I don't just mean tonight, but I mean over the course of this entire series. We should all express our deep and heartfelt gratitude to him, whether that's a hand clap emoji or whether that is some comment in the chat on Zoom or on Facebook, whether you just find his email and send him a note. I believe all of our mothers, fathers, grandmothers, and grandfathers taught us, if someone does something good for you and to you, you ought to say thank you. And Dr. Forbes, I say on behalf of this body of people who represent the community and the church, I say thank you so much. I feel informed and blessed by that. So we're going to take some time now to take a few questions. So if you will, if you're on Zoom, just put your questions in the chat. And if you're on Facebook, just put your questions in the comment section, and we'll do our best to go back and forth because we'll be navigating both. So bear with us, and we'll try to get through most of them, but we want to be a good steward of the time contract that you've given us. And we want Dr. Forbes to get replenished tonight too, because he's really poured out tonight. So if you have some questions, please feel free to put them in the chat or the comment sections, and we'll do our best to do that. With that in mind, Reverend Denise, take us away. Are there any questions we have so far?
Sure. Yes, sir. We do have a question, Dr. Forbes. One of the questions was asked earlier. Could you address the difference between psychiatry and Christian counseling?
So the difference between the two is the training. A psychiatrist is a medical doctor who is trained in all of these conditions that I just described and a whole lot more, and also has prescriptive authority, so they can prescribe medications. Christian counseling is counseling that has as its foundation biblical Christian principles in addressing those same disorders, but a Christian counselor is not a diagnostician. They don't prescribe medications, but they are certainly essential, particularly for people who are Christians, to be able to put their behavioral health diagnoses in context. But again, they don't diagnose diseases or treat with medication, but they understand the importance of how we think and feel, the role of our faith, the power of prayer, and are essential, frankly, for many believers who struggle with behavioral health diagnoses.
Great, thank you. Another question. Can a person in a euthymic state develop a resiliency to stress?
No, absolutely. Yeah, absolutely. I think that's a great question. You know, it's so being euthymic is where we all want to be. I'm going to take a little license and assume that this person wanted to ask about a dysthymic person who's not depressed, but not too high, not too low. The way that we develop resilience, frankly, is the same for all of us. And then for me, and again, I can only tell you what I've read. The science, what works for me is I know I am what I eat. There is a biology in what you eat, how your body transforms it, where you get your energy and your calories from. And it's very, very important that you eat foods that are not processed, high fat, high sugar foods. Those actually will stress your body, like we talked about in our last discussion. And that chronic low-grade stress will lower your mood. It'll rob you of your energy. And so that can affect you. Exercise is absolutely essential. And I think really focusing on the way you think and how you feel is very important. So I think your health, your relationships are absolutely critical. And then maybe part of working with a psychiatrist or a counselor is getting into some of those areas that you can do, not all at the same time, because that's a big ask, but it's day by day, right? You try to make sure you have a long view, and incrementally, day by day, make better choices about your health and your wellness. It's not going to happen overnight.
Thank you.
I have a question from one of our listeners and viewers on Facebook. This is her question. You said that people use drugs to self-medicate. My question is, can drugs bring on anxiety disorders, i.e. panic attacks?
Can drugs bring on panic attack?
Bring on anxiety disorders, i.e. panic attacks.
Yeah, so yeah, I'm going to try to interpret the question as fairly as I could. Can prescription drugs bring on anxiety? There are medications that can be prescribed that can make you more anxious. If that happens, you need to talk to your doctor about that. Can non-prescribed drugs create anxiety? Absolutely. They can even create psychosis. And so you have to be careful what you're getting. And while there may be there's a lot of money to be made in non-FDA approved homeopathic or naturopathic remedies, most of them are harmless. Most of them don't do anything at all. But I think that if your goal is to take care of yourself, I'm biased obviously towards scientifically proven things that are effective where I'm going to spend my money. And just because someone claims it doesn't mean it's evidence-based. And so, yes, you can increase your risk for anxiety by taking certain medications. And so you just want to be really careful about that.
And I have one more from our Facebook listeners and watchers. And he asks, a lot of people use hypnosis and hypnotherapy to defeat their depression. Would you recommend this? Is it effective? Or is it simply masking the problem?
Yeah, great question. I think, if you asked me this question 10 years ago or 20 years ago, I'd say absolutely not. That's a waste. There is a subpopulation of people who actually do benefit from hypnotherapy. And so it doesn't work for everybody. I would submit it may not work for most people, but there is a subgroup of people who it actually works for. Would I recommend it? That'd probably be towards the bottom of my list of options. Again, you're hearing my bias. I think because so few people benefit, I wouldn't start there because you're probably in the majority. Do you know what I mean? So if things aren't working, I could certainly see exploring that, but I wouldn't start with hypnotherapy because it's just a small group of people that it benefits.
Thank you. This is our final question in the chat for Zoom. Dr. Forbes, please comment on violence in the Black community and coping with anxiety as we live our daily lives.
Can you say the beginning again? It broke you up a little bit.
Oh, I'm sorry. It says, please comment on violence in the Black community and coping with anxiety as we live our daily lives.
Yeah, boy. Violence in the Black community, obviously a problem. Maybe in another context, I can talk to you about growing up in Brooklyn and street gangs and what I learned, but that's probably for a whole other discussion. I will tell you, violence in our community is a massive problem. Nobody likes it. It needs to stop. It is a source of anxiety for us, but I will tell you, as a healthcare provider, I'm much more worried about the sugar and fat content in what we eat, because most of us are going to be harmed by that before we're shot or harmed by violence. And that's not to say that violence is not a problem. It obviously is something that needs to go away. But by sheer numbers, more of us are going to be dealing with stroke, heart disease, diabetes, and all of those complications of our lifestyle than we are from being harmed by violence. And when it comes to anxiety, I would go back to my answer a couple of moments ago around wellness. I think your diet is important, getting exercise, being active, turning off the TV. I'm not giving you any good news right now, but we want to eat the right things. We want to be with the right people. We want to spend our time doing things that are uplifting and not negative. For me, I've gone through periods of time. I love the news, for example. I just stopped watching it because I found that it was making me anxious. It was making me worried about things that I can't control. And so I took a fast from the news. Sometimes you need to take a fast from that stuff because it does affect you. And if you're prone to be anxious, it's even more important for you to make sure you're exercising, you're minimizing the dramatic people in your life, that you learn to establish boundaries. And all of those things, I think, are part of you taking care of yourself so that anxiety doesn't overwhelm you.
Let's hear it one more time for Dr. Michael Forbes.
Thank you, brother.
Oh, my goodness. This has been and was phenomenal, phenomenal, phenomenal. And while I'm at it, I want you all to join me in also thanking Reverend Denise Walker for her stellar leadership and coordination. She really has come in, as always, like a gangbuster, just to help get things done, to bring ideas into fruition, to make something out of nothing. And so we're thankful for her leadership in this entire project. In her reluctant absence, we also want to thank our executive director of the BTC Center 501c3, Dr. Monica Reese, in her reluctant absence, and the board of the BTC Center for their work, and all of those who coordinate projects with the BTC Center. What we're trying to do is always find ways to better serve our community, and this has been an incredible way. I also want to thank our New Life for Baptist Temple for really helping us think outside the box with Christian education. That's why it's called New Life. Learning, involvement, evangelism. And so therefore I'm thankful that we are rethinking that, yes, we teach the scriptures, but we're teaching how to apply the truth of the scriptures in everyone's life. And Dr. Forbes, you've done that and gone beyond that. And we're prayerful for you in all of your work, because we realize how important it is. And we're thankful that you would take your time out to share with us not only your expertise, but do so with great care and love. And I'm glad you mentioned growing up in Brooklyn in the 70s and 80s. I try to tell people from Pittsburgh,
Oh yeah.
That's why we get, I get a little touchy when people walk up behind me and stuff, but
oh yeah, it's different.
It's different. Very different.
Yeah.
And I also would say I'm really also appreciative of the very practical and pragmatic ways you instructed us, so that we're not just learning this important information. And you did put the cookies on the lower shelf. You taught us, I think, some very important and complicated things, and you made it apprehendable and digestible to us. But you gave us things that we can actually do.
Thank you, brother.
Particularly tonight, to think about the kind of people we keep company with, exercising. I feel challenged to not reach for that ice cream, knowing that I'm just trying to deal with stress.
Yeah,
to find healthier ways, pick up some water, and knowing that you're a person of faith helps. And I would say that I know for me, the practice of my faith, being in worship, has helped. It's a resiliency strategy.
Yeah,
Prayer
no doubt,
has been
no
for
doubt.
me as well. Now, with that being said, I'm also a strong advocate to make sure that we get people that are helpful and trained to help us in issues of mental and behavioral health. So I'm not a person that says, oh, you only need the Lord. No, the Lord can send a good psychologist,
Amen.
a good therapist, a good doctor, can use the miracle of modern day medicine to help us. And so in that way, thank you again so much.
So welcome.
As we close tonight, I just want to make a couple of more shameless plugs. So bear with me for about one more minute. And as we do that, there are two events that I want to make everyone aware of as we close tonight. This is not only for those that are present, but they are also as well for those who may know of other people who may want to or need to avail themselves. So on this Saturday, this Saturday, October 16th, from 11 a.m. to 1 p.m., we have our second series in the safe and healthy relationships. And this is on domestic violence. We have Dr. Lawana Butler, PhD, and MSCP and MBA. She's an author and adjunct professor. She will be facilitating session 2, which is on intimate partner violence, religion, and the role of the African American church. This is for women only. The first one was for all, but this one's for the sisters only, because we want to be able to address some particular issues and be of help to people who may be in particular situations. This is, of course, in conjunction with October, which is Domestic Violence Awareness Month. And we're also in partnership with the BTC Center and Baptist Temple Church. You do need to register. We're asking you to register, and there is still time to register. And that number is 412-254-3461. That's 412-254-3461. Now, for those that may not have registered already because we were going to be in building, guess what? We heard you loudly and clearly. And so we've changed the venue, and it will be facilitated via Zoom. So this will be via Zoom. So this may mean, oh, I will attend. And that's what we're looking for. It will be facilitated via Zoom so you can be at home while you do it. And so please, but we ask you to please register as soon as possible so that we can adequately prepare for you. I would dare say, based on our track record, you don't want to miss this again. That is, the registration number is 412-254-3461. And the session 2 is this Saturday, October 16th, from 11 to 1 p.m. Jump on that right now. One more thing. On the following Saturday, this is Saturday, October 23rd, from 10 a.m. to 12 noon, we have a vaccination event and health screening. Listen up. This is a vaccination event and health screening. You can get a flu vaccination. You can get a first COVID vaccination. And you can also get a COVID booster if you've been vaccinated already. And you can get a blood pressure screening, all in one day, one event in the same place. It's our vaccination event and health screening. Again, you can get a flu vaccination. You can get a COVID, your first COVID vaccination. You can get a COVID booster if you've already gotten your vaccinations. And you can get a blood pressure screening on Saturday, October 3rd, 23rd, I should say, from 10 a.m. to 12 noon. Go ahead and jump in, Reverend Denise. You going to add something?
Yes, Pastor, thank you. I just want to let everyone know that the Pfizer vaccine will be available for children ages 12 years and up. We will also have the Johnson & Johnson vaccination for 18 years old and up. And for the flu vaccinations, that's for 6 months of age and up. And we will also be offering for those that are getting a flu vaccination a gift card from the Giant Eagle Pharmacy as an incentive.
Yes. Say that one more time for the people in the back.
You will get a Giant Eagle gift card for your flu vaccinations. And please, I want to remind you also for the flu vaccines to bring your insurance card. The COVID vaccines, you don't need an insurance card, but please, for the flu only, bring your insurance cards. Thank you.
And which vaccinations and boosters will be available, just to remind everyone?
Just a reminder, we will just have the Pfizer and the Johnson & Johnson. For those that are concerned about Moderna, it hasn't been approved yet. It will just be for Pfizer and Johnson & Johnson and just the flu vaccines.
Thank you very much. So that again, that vaccination event and health screening is on Saturday, October 23rd, 10 a.m. to 12 noon at the Baptist Temple Church, 7241 Ray Street, Pittsburgh, PA 15208. We want to thank our community partners, Alma Illery Health Center, the Bethany Christian Ministry, the Allegheny Health Network, Rite Aid, Baptist Temple, and now Giant Eagle. We want to thank Giant Eagle as well for that. And this program, as well as others, has been made possible by grants through the Pittsburgh Foundation. So let's give it up for our community partners and for the Pittsburgh Foundation for being philanthropic and making sure this education takes place. So I know I'm going to go on a risk and say that I know that you were thoroughly blessed, educated, informed. Now let's go live out what we've learned. If you remember, we began this with a small teaching from 1 John 3, and the writer of that letter, some would say the elder of the church, was writing to a general epistle to the people, and his prayer was that they would prosper in health as their soul prospers. And I'll end on that. Our prayer, our hope, and our endeavor is that you would not only prosper in your spirit and soul, but likewise you would prosper in regards to your health in body, mind, soul, and spirit. So thank you all for taking the time out. Look out for our future events, and we'll see you soon. Grace and peace. Thank you again, Dr. Forbes. Thank you, Reverend Denise. Thank you all for attending.
God bless you. Thank you.
Good job.
Thank you, Pastor. I just received word that Moderna was approved 2 hours ago.
How about that?
Dr. Forbes just shared that with me.
So we'll see what they say with regards to the clinic. So we will see.
Absolutely.
So you all take care. Those on Facebook, YouTube, Twitter, on Zoom.